The half face that we see.
Yeah.
Yes, that's me.
Fix the
All right,
screen.
guys.
Fix the screen so we can see you better.
Welcome, everyone, to our next Journal Club. Today, we have a presentation by Ermelinda Ndoka, who's a second-year medical student. The title of the article is
At Loyola, which is one of the best medical schools in the United States. Don't forget
That's right.
that. Give her some credit. She worked hard for that.
Absolutely. So the name of the article is Thrombectomy Complications in Large Vessel Occlusions, Incidence, Predictors, and Clinical Impact in ETIS Registry. And this article presentation will be moderated by Dr. Elton Mustafari. First, for Ermelinda Ndoka, she's a second-year medical student at Loyola University, Chicago's Stritch School of Medicine, where she's, again, second year. She graduated from University of Michigan in 2020 with a bachelor's degree in neuroscience. And Ermelinda is currently interested in different specialties and looks forward to clinical rotations to help her choose one. So everybody feel free to share your favorite specialty at the end of the presentation.
You can tell she's already smarter than all of us.
Exactly.
Like, I'm not saying anything.
Dr. Mustafari is a board-certified, fellowship-trained radiologist specializing in neuroradiology. He earned his medical degree in 2012 from Des Moines University College of Osteopathic Medicine. He completed his residency in diagnostic radiology at the University of Illinois College of Medicine at Peoria, and he was a chief resident there at the same time as well. He completed his fellowship in neuroradiology at the Medical College of Wisconsin. And that's it. Prior to medical school, Dr. Mustafari earned his Bachelor of Science in Biochemistry from University of Wisconsin Medicine, and he's a member of the Radiology Society of North America, the American Society of Neuroradiology, and the American College of Radiology. On his free time, I guess he has some free time, Dr. Mustafari enjoys spending time with his family and enjoys fishing, biking, and photography. That's wonderful. Thank you, Dr. Mustafari, for taking the time to moderate.
Lake fishing or deep sea fishing?
I'm guessing lake or river fishing. Where exactly?
Real fish or are you just doing a lake? Lake fishing? That's not fishing.
All right.
There's a lot of free time, Dr. Chausha, non-surgical subspecialties out there.
Yeah, so Ermelinda Ndoka, take note.
Oh, that was a good one there, Edion. Excellent.
All right, so why don't we get started? Ermelinda, you may want to take over the presentation, the screen, so you can share your.
Yeah, so hi, everybody. I actually just had a little mishap and my computer stopped working. So I'm logged in from my iPad and you again will be sharing my slides. So hopefully this will be not too complicated. All right, so again, thanks everybody. We'll go ahead and get started. So I'm going to give a brief overview of stroke and its management, and then I'll go ahead and move into the article that we have all read, hopefully, and then I'll give the floor to Dr. Mustafari to talk a little bit more about the clinical relevance of this. Next slide, please.
Can't you control it? Oh, okay.
So just to give us a brief overview, like I mentioned, a stroke is a sudden onset focal neurological deficit that can be explained by a vascular cause. And often how this occurs is when a vessel that is carrying oxygen and nutrients into or in the brain is blocked or ends up bursting. Next slide, please. If you could go back one. Thank you. So there are two different types of major strokes. One is ischemic and one is hemorrhagic. The ischemic kind is more common. So about 85% of strokes that are seen are going to be ischemic, and then the other 15% are hemorrhagic. So ischemic, like I mentioned before, is going to be the type where the vessel that's carrying the blood and the oxygen and the nutrients is blocked and therefore leads to cell death in the area that is being perfused by it. And then on the other hand, hemorrhagic stroke is going to be the one where the vessel bursts, and then it can also lead to secondary ischemic strokes because of the pooling and the compression that happens. So since the paper that we'll be discussing in a little bit focuses on thrombectomies, and this is the treatment for ischemic strokes, I'll go ahead and talk a little bit about the pathophysiology of just ischemic strokes. So when we have that vascular occlusion that I mentioned before, this will obviously lead to cerebral flow decreasing. And then since there's less blood flowing to that area, there's going to also be less oxygen and less glucose. And when you have a decrease in these two molecules, that's going to end up changing the cellular metabolism that's happening in those cells and those neurons. And then that will lead to a decrease or no energy producing processes happening. And then once you don't have these processes, that will lead to a change in the cell membranes, which can affect the ion movement and transportation. And that will lead to action potentials potentially not being able to fire. That will then move into necrosis and apoptosis, where we end up seeing cell death. And these are both intertwined with inflammation. So now that I mentioned a little bit about the molecular mechanisms that are happening in stroke, some of the important symptoms that can be seen in patients who are experiencing a stroke are headache, although this is more common in things like subarachnoid hemorrhages. Strokes can be painless, but often we end up seeing different neurological deficits, including weakness, which can be one-sided. We see slurred speech, confusion, and facial droop, and most people are probably familiar with the acronym FAST, which stands for facial droop, arm weakness, speech difficulties, and then time. So time is going to be key, as I'll mention later when dealing with stroke. So then how do we get an ischemic stroke? So there can be different risk factors, such as high blood pressure, heart disease, diabetes, smoking, oral contraceptives, or a previous history of transient ischemic attacks, which are basically like little mini strokes. And these can come from thromboembolisms, atherosclerotic disease, watershed areas when there's a time of brief hypoperfusion of the brain, or it can come from cardioembolic etiologies. And then how do we look at someone when they come in? We can do carotid ultrasounds, echoes, blood testing, and of course, one of the main things we do is imaging, including MRIs and CTs. And the different etiologies of the stroke, depending on where it's coming from, will lead to different looks on the imaging. So for example, if it's an embolism, it might be larger, but if it's a lacunar stroke, it's going to be smaller because the vessels that are affected by these two different ways of getting a stroke are going to be either large or small vessels, and those will look different on imaging. Next slide, please. So now that we've talked about how we get a stroke, how it looks, it's important to talk about the treatment. And here you have probably heard that time is brain and that time is key when dealing with stroke. So the first line therapy is going to be intravenous alteplase, and this has to be given very quickly. The cutoff is basically 4.5 hours since symptom onset when you can give this. But of course, clinically speaking, you want to do that as soon as possible. And if you look at some of the guidelines that are on the right there in the box, you can see that from the time that a patient comes to the hospital, you want them to see the physician in about 10 minutes, and then the stroke team in 15. You want them to get a CT or MRI in about 25 minutes. You want them to get that interpreted in 45. And then you want them to get the treatment in less than or 60 minutes. So that will be the IV alteplase. And then where it says door to artery, that's going to be if the patient is eligible to get thrombectomy, which we'll talk about later. You want them to get it in less than 90 minutes, although technically they can get it within 24 hours, as you can see there, from symptom onset. And then you want them to be reperfused within 120 minutes. So once all of these have been taken care of, then we want to think about antithrombotic or anticoagulant therapy, statin therapy, and then of course, as with basically all patients, blood pressure management. So just to give a quick overview, hopefully this video will work. It's about 2 minutes, but I didn't have a good idea of what a thrombectomy is. So I thought this might be helpful in giving us a picture of how it works.
Coming with typical stroke symptoms, some of those strokes are caused by blood clots in smaller blood vessels, and some of them are caused by blood clots in larger blood vessels. And if the blood vessels that are affected are larger in size, meaning a couple of millimeters in diameter, then these patients may qualify for mechanical thrombectomy. It's minimally invasive endovascular procedure, which means that we go through the groin blood vessels and then advance small catheters all the way up to the neck vessels, eventually to the brain. Through those catheters, we can use several different types of devices to remove blood clots from the brain, basically pulling blood clots out of the brain with the help of our catheters and endovascular tools. Recovery is not really dependent on the procedure itself. Once we remove our catheters, the hole seals up within a few hours. It depends on how severe the stroke symptoms were or how severe the stroke was. And the recovery, in an optimal case, if the procedure goes well and there's no significant brain damage, then yes, we've seen patients walking the next day after a stroke. If there is more damage, then it could take a couple of days and even rehabilitation stay first. We have a system that all of our patients are followed, usually 2 to 4 week time window after discharge from the hospital. When we see them in clinic, evaluate them, make sure their workup has been completed for the stroke, they are on the right medications to prevent further strokes. The patient is not taken care of by one person when they arrive to the Cleveland Clinic, but a whole team. Nurses, ED physicians, neurologists, endovascular specialists are all trained to deal with these situations.
So that's pretty amazing. I think it's so cool that they're able to do that. But now that we've seen how thrombectomies kind of work, I thought it might be a good idea before we head into the paper to look at some of the cerebral vascular perfusion, because it might be helpful when we look at what they're referring to. So as you can see, after ascending to the brain, the internal carotid arteries split into the anterior and middle cerebral arteries. And the anterior cerebral arteries supply the middle and frontal and parietal lobes, and they're connected by the anterior communicating artery, which is that little piece in the middle there. The middle cerebral arteries supply most of the lateral surface of the cerebral hemispheres, and these can be split into the proximal M1 segment and the more distal M2 segment. And then we can see that's basically going to be the anterior circulation. And then we can see that the vertebral arteries are going to be kind of in charge of doing the posterior circulation, which they didn't mention too much in the paper since it's not super relevant to thrombectomies. But the anterior cerebral internal carotid and the posterior cerebral arteries of both sides of the brain are all connected, forming what is known as the circle of Willis. And this is an important interconnection because it can allow blood flow to continue if one of these major vessels is blocked on either side of the brain. So then once someone might have a stroke, some of the complications that can follow them are blood clots, whether that's a deep venous thrombus or a pulmonary embolism. They can have things like urinary tract infections, bowel and bladder problems. The risk of pneumonia can be higher. The muscle weakness can be prolonged. They can have bed sores and obviously mobility problems and falls depending on what kind of stroke and how severe it was. So with that overview, hopefully it was a little bit helpful. We'll go ahead and move into the paper. So this was the paper titled Thrombectomy Complications in Large Vessel Occlusions, Incidence, Predictors, and Clinical Impact in the EDIS Registry. And this was a paper published in Stroke in December of 2021 by Dr. Ngo and his colleagues. So just a little bit of background on the paper. They knew that thrombectomy was a very good treatment for anterior circulation acute ischemic stroke due to large vessel occlusion. But there had not been much research done on whether there were complications or what kind of complications or how this would affect the clinical outcome. So this is what they were going to try to look at. So do these complications that are faced after thrombectomy, do they lead to worse clinical outcomes? That was basically their question. Knowing more can help optimize procedures. So essentially, they were going to see what the complication rate is after thrombectomy, what the clinical characteristics might look like, what those risk factors are, and the outcomes of the thrombectomies. So in order to go about answering those questions, they had a population already basically ready to go for them. The data was from the Endovascular Treatment in Ischemic Stroke Registry, which is an ongoing prospective observational study, and it looks at 18 stroke centers in France between the dates of January 2015 and May 2020. So they had quite a long span of time there with 18 stroke centers, but it was just in France. And then some of the inclusion criteria they used were obviously anterior large vessel occlusions, and then patients who had thrombectomy using stent retrievers or large bore aspiration catheters. And they did include both those who had had IV alteplase or not. So thrombectomy may have been the only treatment, or it may have been an add-on treatment after the IV drugs were given.
Can I just
And
ask
then-
you a question at this point? Were there any worrisome exclusion characteristics?
I don't think they had any worrisome, but they definitely had some, like depending on age, like if someone was less than 18, or if they didn't know what the outcome of the thrombectomy was. So if they didn't have a clear-cut complication that they weren't able to follow, then those were the patients, some of the patients that they excluded.
Was that a significant numerator, and does that establish a selection bias in that paper?
To my knowledge, I don't think so. It wasn't a super large number. I think it was maybe a few hundred. And we can look at the numbers in a few slides. I don't remember them off the top of my head, but it was not huge.
You should be asking yourself that question. When you look at inclusion, you should look at exclusion and figure out, does it set up in a selection bias? Because that can change the nature of an observational study. I'm sorry to interrupt you. All right,
No,
go
no
ahead.
worries. That was a good question.
Thank you.
So then when looking at the outcomes, they wanted to see what exactly the procedure complications were. So they looked at emboli to a new territory, looking using an angiograph, and then they looked at vessel perforations and arterial dissections. And then when looking at the improvement, they looked at either complete recovery or and with regards to if a patient improved, they were seeing whether there was complete recovery or if there was a decrease by 4 or more points on the NIH stroke scale, which basically measures any neurologic deficits after having a stroke and is more comprehensive than the scale that we have on the right of the slide here, which is the modified Rankin scale score. I'm sorry. And they looked at that one for favorable or excellent outcomes. So if the score was 0 to 2 immediately, or if the score was 0 to 1 in 90 days, then they considered that favorable or excellent. And you can see that as the numbers go higher there on the scale, that means that the patient is worse, and there was not as much improvement if the numbers were higher. And then looking at the results, which I thought were pretty interesting, they saw that younger age, higher initial NIH stroke scale score, lower proportion of M1 or M2 occlusions, lower clot burden score, higher likelihood to have an Alberta stroke program early CT scale score of less than 7, and lower likelihood to have a stroke of cardioembolic etiology were associated with these emboli to new places. And then terminal internal carotid artery or tandem occlusions and the total number of passes were predictors of ENTs. And then ENTs associated with lower rate of good perfusion were seen. So if the patient had ENTs, then they had, it was less likely that they would have good perfusion. And then those patients had increased likelihood of developing symptomatic intracranial hemorrhage. So I thought it was interesting, some of these that they found, but they discussed some of them later on too. Next slide, please. So then when looking at perforations and dissections, which were the other two complications that they were looking at, they saw that worse MRS scores at 90 days were seen after perforations. They also found higher mortality and higher incidence of symptomatic intracranial hemorrhage. And also when looking at dissections, they found an inferior rate of successful reperfusion. And although this obviously is not good, they did not see any worse clinical outcomes except a diminished rate of early neurological improvement. So just to kind of give a summary of what we know so far from the paper. So they started with 7,281 patients who had a thrombectomy in this EDIS registry. And then they narrowed that down to 4,613 because they were looking at that anterior circulation, either middle cerebral artery, internal carotid, terminal, or tandem occlusion strokes. And they ended up excluding those few hundred that I mentioned before due to age, not actually having a thrombectomy done, or if they didn't know the status of the complications. So their final population was 4,029 people that they were looking at. And they did not clearly find a negligible amount of complications. There were about 8%, which is 322 people that had complications. And most of those were ENTs, although some were perforations and dissections, as you can see the breakdown there. So then, like I mentioned before, there were not a small number of complications, although 8% does not seem big. There were 322 people that were affected, and ENTs were the most frequent. ENTs and perforations they found that they were related to occlusion location and increased number of passes for ENTs, but not to the actual technique that was used to perform the thrombectomy. And then these both ended up leading to increased disability and mortality. Something brief that they mentioned, very briefly actually, was diffusion weighted imaging. So some studies had shown that emboli to the same or a new territory may occur in up to a third of patients post thrombectomy. But obviously, as I mentioned before, they didn't really see this. They only saw about 5.2%, I think. So what they kind of hinted at was that DWIs may be a better imaging tool to study the endpoint they were looking at because of its higher sensitivity. So then they kind of looked at why internal carotid artery and tandem occlusion might be important predictors for ENTs and perforations. And they mentioned that it might be because both of these have larger clots and they might be technically more difficult. And sometimes the surgeon might have to go in blind in overlapping anatomies, which is not easy, as you can imagine. And then why would the number of passes be an important predictor? Well, similarly, this might reflect a more difficult clot to get at, and it could increase the likelihood of thrombus fragmentation. So then going back to perforations, they saw a poorer outcome. So at 90 days, 40.7% of the patients had died, and the overall rate of poor outcome was almost 75%. And then dissections were seen more frequently in younger patients with no cardiovascular risk factors. And potentially this might be because they had some other underlying disease or even maybe increased vascular vulnerability somehow. And as I kind of hinted at earlier, there were some limitations to the study in that it was a retrospective registry. They didn't really have any data quality control or a central adjudication of images and clinical parameters. And the data was only from France, although it was from 18 stroke centers, which is might be or might sound like a good variety, but if it's only from one country, then I'm not sure how widely it can be applied.
Actually, that's probably the one saving grace for the paper, because the French are relatively diverse. It's not a completely homogeneous country, and they're very religious about their registries.
I did not know that. Learn something new every day. So then touching on the conclusions, as I've stated before, the ENTs and perforations have a substantial negative clinical effect, and they're related to terminal, carotid, and tandem occlusions, and an increased number of passes for ENTs. And then thrombectomy technique had actually no impact on the procedural complications. And I think what would be interesting kind of to follow up is see how they were looking at these questions they had because they wanted to potentially improve procedures, but I'm not sure that just this paper and the data they found can be super useful in changing any procedures or protocols, because if someone comes in with a stroke, I don't think they're going to sit there and think about this 8% complication rate. They're probably going to be taken to get a thrombectomy if they're eligible. So maybe if more data can be gathered, or if this can be more widely applied, potentially there might be some changes in protocols, but I'm not sure that it will all come from this paper. And then just by way of acknowledging all the people who helped me, I'd like to thank Dr. Mustafaray, Dr. Cruzio, and AAMS for letting me present. And I'll hand the floor over to Dr. Mustafaray to talk about some of the clinical practical things.
Can Dr. Mustafari wait one moment, please? And Melinda, that was a spectacular presentation. It was elegant, it was well done, it was clear, crisp, and you demonstrated complete command of the topic and knowledge. For a second-year medical student, I'm incredibly impressed. You really did a very, very nice job.
Thank you.
I compliment you. Now, I apologize, Dr. Mustafa.
Oh, no, you're fine. Yeah, Melinda, thank you again. Nice job. I have a very short presentation. Hopefully it shouldn't take longer than 5 or 10 minutes. You'll kind of tie to the paper and to the topic. Hopefully that's okay with everyone. Can you guys see this?
No, okay, yes, we see you now.
What about the PowerPoint?
Yeah, we see the PowerPoint.
So I do mainly the imaging portion only with the stroke patient. As a radiologist, we don't get involved with management or treatment after patients go to the ICU or neuro ICU or outpatient. When initially the patient presents with stroke symptoms or suspected stroke symptoms, almost universally, at least in the United States, we'll get these 3 studies: the CT head without contrast, the CTA head and neck, and CT perfusion. There are certain academic centers that are highly advanced. They have advanced MRI protocols that's what they decide to do, but at this day and age, we cannot do everything like that across smaller community centers or mid-city hospitals. So the CT head without contrast, CTA head and neck, and CT perfusion are the most commonly done, and all 3 studies are pretty much done in the same time. CT head, for obvious reasons, it's to include whether there's a big stroke or not, whether there is loss of gray white matter differentiation, or whether there's other complications such as bleeding, mass lesions, infection, or any other findings that could mimic a stroke. CTA head and neck is done to, the main reason, evaluate where the large vessel occlusion is, but the other reasons are to evaluate thrombus load, to evaluate for variant anatomy. Ermelinda talked about, for example, the circle of Willis. Well, the circle of Willis is complete in very, 50% of patients, I would say, from what I see. At least every other patient that we read CTAs on, they have some sort of variant. Either the posterior communicating arteries are missing or the anterior communicating artery is missing. And then the last thing that we do is CT perfusion. And, the rest of this short presentation is going to focus on this because it's CT perfusion that in the past couple of years, or 4 years actually, changed stroke management into a large way. When we do the CT perfusion, we evaluate 4 criteria: cerebral blood volume, cerebral blood flow, mean transit time, and time to max. And these are the definitions here. So cerebral blood flow is per minute, so it's a time unit. And then time max is the time from, how delayed contrast comes to the side that's occluded compared to the contralateral normal side. CT perfusion has 2 components, has a qualitative component and then has a quantitative component. A few years ago, it used to be just the qualitative component where we would look at the perfusion maps and we would focus on decreased cerebral blood flow, decreased cerebral blood volume, and increased mean transit time, or Tmax, and that's what defined the core infarct. And we'd also focus whether we saw an area of increased Tmax or prolonged mean transit time, but maintained cerebral blood volume, and that defines an area of penumbra. And for thrombectomy, for mechanical thrombectomy, this is what we're going after. We're going after the area of penumbra. And so this is a kind of summary map on perfusion imaging. This is the qualitative component of the study, where we'll have the CT head portion and the cerebral blood volume, cerebral blood flow, mean transit time, and Tmax. And if, like, I can show you on the Tmax here, we can tell that there is a large MCA occlusion. It's very prolonged mean transit time. But the question is this all area core infarct, a large infarct that we cannot do nothing about, or can we do something about this? And that's where we focus on the cerebral blood volume and the CT head. We see that there's no loss of gray white matter differentiation in this patient. So this patient, potentially we could save a lot of this brain if we go after. In this area, for example, we see very large Tmax abnormality, but on cerebral blood volume, it's fairly symmetric. So this shows that this area is salvageable if we do thrombectomy. But as we move inferior, for example, you can see the asymmetry here. And on the left, this small area is a core infarct. There's nothing we can do about this anymore. So this is how we used to approach perfusion imaging 3 or 4 years ago. Then in 2018, these 2 landmark trials came out, the DAWN and the Diffuse 3 trial, and they extended their thrombectomy window from 6 hours. So if before 2018, if you had a stroke and you presented 6 hours afterwards, they would not do anything for you mechanical thrombectomy wise, whereas now it's up to 24 hours. And both of these trials utilize CT perfusion. And they showed that even up to 24 hours, patients with stroke had functional independence in 90 days that was better in the thrombectomy group versus the control group. They did use some target profile, so it's not that everyone that comes with a stroke we take for thrombectomy, they have to have a certain profile. We have to make sure that the core infarct, so the area that there's nothing that we can do about, is less than 70 ml. If it's bigger than that, and then you reperfuse the brain, you run the risk of causing hemorrhagic conversion in the stroke. And then we also want the area of hypoperfusion, so the penumbra to the ischemic core, to be about 1.8 larger. Almost all over the US, we use Rapid AI has taken over. This is a AI software that we utilize. And based on the DAWN and the diffuse 3 trials. These are the parameters that will define what the core infarct is and what a penumbra is. So this is like a rapid AI summary map. Shows here in pink, this area is a core infarct, and this is the quantitative component of AI, which is new over the past few years. It shows that 46 ml of the brain parenchyma is dead. There's nothing we can do about it. However, the perfusion abnormality is 111 ml. So there is an area of penumbra of 65 ml. So if this patient is within 24 hours, we could save 65 ml. And this is another example where core infarct is 29 ml, left MCA distribution shows here there's a left MCA occlusion, so large vessel occlusion, area of increased Tmax 97 ml, so there's a large about 70 ml of penumbra that we can save. So we'll do these studies, and then depend, certain patients. So if patients fit this criteria, then they go ahead and move on to the next step, which is the mechanical thrombectomy. And then we can, that was about it on my part. So
Could we ask Dr. Chaya, who's a vascular surgeon, and we're fortunate to have him as a member, and to give a comment, because he actually does this stuff, or do you, Edion?
I like to be in control of these things. So if there's something that I do, it's probably limited to the extracranial vessels. And I've done a couple of times in training, and once as a young attending where I had to do an open embolectomy for common carotid clot and proximal ICA clot. I do use the same similar suction catheters for SMA thrombus or lower extremity tibial disease. The challenge that I have with those catheters, and I'm sure Elton is going to talk about it, is that when you cross that clot with the wire with the catheter, there's always a chance of pushing that clot further distally. So the ENT that we're seeing in this kind of patients population is because we're actually pushing the clot further away. And on our best technical skills trying to get that clot out, we try to manipulate the wires, and hence the vessel dissection perforation happen. I'm not sure I answered your question. I might have diverted there a little bit, but
Well, I just wanted to get your input as a vascular surgeon too. We're lucky to have you.
Yeah. So, well, the thing with this kind of stuff is that, the MRI on the acute stroke patients, I really don't see any user benefit on it. The CT perfusion has largely in the acute care setting has replaced MRI altogether, in my opinion. I feel like, unless Elton has any other options or
so there, like I mentioned, there is academic. So where I did, for example, my fellowship, they had technologists 24/7. They had specific stroke dedicated protocols for MRI, so they could do a patient in 10 minutes and did not affect. Whereas at a community hospital, or where I'm at currently, even though we're a large center.
Academics aside, what kind of information are you getting from the MRI that the CT perfusion is not getting to you?
So I mean, they're doing, so you could, a limited target, for example, you could do the diffusion weighted imaging. So we will show you the stroke volume. And then when you get afterwards, if you compare the two, you could actually have stroke in different territories in up to 30% of the cases. So I know they said about 8% here, but in real life, that could be, much higher. So you could get that. You could find a true, if it's a restricted diffusion, you could, for a fact what the true core infarct is. Whereas in CT perfusion, there's always some variability, whether the patient moves, or depending on the contrast bolus timing, it might not be the best, right? If the collaterals are not the greatest.
On a procedure, would you go after an occluded vessel, or would you go a penumbra in the MRI?
What do you mean?
So supposedly you have an anterior communicating artery or MCA occlusion, and you've seen that on cerebral angiogram. Would you go after that vessel occlusion to suction it out, or would you go after what you saw on the MRI? So
it depends, because if the core infarct is large, it depends. If the core infarct is, greater than a third of the MCA territory, then there's no way we're going after that because the risk of complication is too large. And there are cases where you'll get the CT and the loss of gray white matter differentiation is not the greatest. You get the CT perfusion and it doesn't look bad, but then you get an MRI and all of a sudden you have a huge infarct. And those are the cases that we'll often see with hemorrhagic conversion of, and they don't happen that often, but they do happen.
Could both of you comment on the necessity of going to a stroke center? An institution that's dedicated as a stroke center. Edion, Dr. Mustafarai, could you comment on that? Should patients be diverted from a community hospital to a stroke center?
If they are within the 24-hour time window and if they fit the thrombectomy criteria, because again, remember, not every patient fits the thrombectomy criteria.
Yeah, but you don't know that when the ambulance come, and the EMT thinks we've got a stroke. What do you do?
Oh, so where do they? Oh, okay. That I see.
Where do they take them, to a stroke center or the nearest?
For us, we don't. But again, we can transfer patients in Milwaukee, for example. We can transfer them within 15 minutes everywhere. So we cover 6 different hospitals.
My understanding
Takes
is that
15 minutes to get them out of the ambulance. I mean, let's be honest.
My understanding is that stroke patients go to a stroke center.
I think
Well, I'm going to give you an example. My next door neighbor, this is actually a true story, 70-year-old executive, non-smoker, diabetic, starts slurring his speech. His wife calls me and says there's something wrong. I ask her to call an ambulance. They take him to my hospital, and he had a massive stroke, thrombectomized with minimally invasive techniques, and he was home in 2 days, walking and really looking good.
Sounds like second smoke hand effect to me.
So here, for example,
I don't smoke in his backyard.
Again, it depends. Here we don't send them automatically to the main hospital where we're located, but we do cover all the it's 7 hospitals in Milwaukee area that we cover, and we'll read the stroke studies pretty much from all of them. Okay. And if a patient does fit the criteria, then they're automatically transferred. Because you have to understand, not IR doctor will only cover one hospital.
I'm functioning as the moderator, and I'm not. I don't see Lorenz. He's got his name up there. He must.
I'm here. I was.
Come on up, Lorenz.
Very interested.
Hi there, Jelly Bobby.
So I'll let you go. But I think the question, because I can tell you about the area where I'm at actually. Only one of our hospital systems here is actually a basically stroke accredited center. So the ambulances in the region will divert all patients to that facility because of, once they got their accreditation and they got their agreements put in place. So I think I guess the answer to Dr. Chausha's questions, it's probably regionally or locally decided, or that decision is made depending on the availability of the facilities. Because and I'm sure Dr. Mustafa, Dr. Chai can chip in here, but time is brain, right? So you're gonna need to take them to a facility to figure out where they can get the best care. But if you don't have access to that facility in a reasonable amount of time, you're not going to drive for 3 hours to go to a stroke center. If they can get scanned, for example, and get an answer what the problem is, in 10 minutes.
I got to tell you, to me, this is fantastic, because when I was an intern in 1979 at Columbia, you came in with a stroke, that was it. It was all over. You got put into a bed, they got rehab, and they got neurology involved. You didn't even get a CAT scan. It was horrible. And now we can save so many of these people with all of this testing. This is just really a fantastic thing that you're all doing. And
Dr. Hoja, another point is the threshold, and again, I'm not sure there's any ED doctors here, but the threshold of ED colic strokes is very, very low. So right? On a typical shift among like the 6 hospitals, for example, that we cover, we will read anywhere from 15 to 20 so-called stroke cases.
Really?
but it'll be one or two of them that are actually true strokes, and then maybe one of them a shift that will benefit from thrombectomy. The other ones could be either lacunar infarct, or you could have other causes like seizures. So the idea of sending every quote unquote stroke patient to one center is, I just don't see it as feasible, given how much we image for stroke.
Your discussion tonight, Elton, your discussion tonight was fantastic, and I really appreciate it because it's clear to me, and I'm not that bright, so thank you.
I have a couple of questions, Elton. So,
Yeah.
what happens to the ICA bifurcation if there's disease there and that was the culprit after you've cleared up the intracranial vessels? Then that was number one. And what is the antiplatelet therapy that these folks are staying during and after the procedure?
So like I said, I'm a radiologist, so I'm not.
He's a radiologist. Why are you picking that?
He
Why
goes
are
home
you
after he's
picking
done.
on
He doesn't take care of the patient afterwards.
You're the guy that takes care of the patient. You put him on.
You're
the
asking a radiologist about. But I believe it's a dual. If my understanding is, isn't it a dual antiplatelet therapy? So aspirin and Plavix. I think that's a standard of care, I believe.
He's reading those X-rays from home. What are you talking about? He's not even in the hospital.
I was under the impression it was a neuroradiologist. That's why I
That's okay.
No, so it's my understanding is it's dual therapy, at least the last time. It's Plavix and aspirin.
Didn't you see his biography? His pastimes or his family. He's at home reading the X-rays. He's not in the hospital like you.
Sometimes.
You're still single there, Eddie, and I know all about you.
Oh. All right. So with that comment, anybody else has any other questions for Dr. Mustafaria or for our really wonderful medical student, Ermelinda Ndoka?
Ermelinda, you're fantastic. Don't
That was a
become a
great
vascular
presentation,
surgeon
too.
or a radiologist. Do something worthwhile. Dr. Nora.
Hi guys. I'm sorry. I was like listening on and off, but a great presentation, Ermelinda and Dr. Mustafarai. I would like to say for Ermelinda, this is her second journal club. She's amazing. She's great. The presentation was outstanding. The other thing is she's organizing this health fair in Chicago on March 20th. So kudos to her. She's so
Excellent.
enthusiastic. Yeah, I'm really proud of Ermelinda. Every time I see her message, I'm like, oh, it's Ermelinda. Like I get so excited because I know she's bringing something really good to community and to other medical students and to the society. So thank you, Ermelinda.
And to sick people everywhere. God bless you.
God bless you.
Yes.
Thank you all. It helps to have supportive people like you to root me on.
And then also Dr. Mustafarai I just reached out to him, and first thing he said, yes, of course, thank you, and great presentation.
He's a member now, right?
Yes, he is. Yeah, he was a member from day one. Yeah, he's a member from day one.
Back to the journal club. You need a radiologist at the journal club.
That's right.
Absolutely. Well, thank you. And thank you, Lawrence, and everyone else for coming tonight, for joining us tonight.
This was a great presentation. Yeah, thanks again.
This was
Ermelinda
fun.
and
I
Dr.
really
Mustafarai.
enjoyed it.
No, thank you.
Can we do it again? Same topic?
Let's have Dr. Chaya do a moderation next time. Let's pick an article.
When's the next one, Nora?
Oh, anytime. You just say it. I actually have a medical student who approached me, so let's see, we can work something out.
The medical student approached you? Excellent.
Oh, like Ermelinda, she asked me, it's like, hey, can I do a neuro presentation? I said, of course, anytime.
Well, if it's a topic I know, I'll be happy to help. If I don't know, I'll be happy to help anyway and just fake it. I'm an old man.
Let's do IBD next month.
What's that?
IBD.
Yeah.
Okay.
Oh, wonderful.
Promising
That's
it.
going to be very interesting.
Yeah.
Oh, thank you.
Yes.
Okay. Okay.
Awesome.
Everybody get
okay.
questions ready for Dr. Chaushai so that you can start answering next time.
Oh, this is gonna be big. This is gonna be big. And I'll see you, Dr. Chaushai, soon too.
I will see you for the fair in Stamford, and I'm going to try to make the dinner Because I hear it's free food. I'm coming.
Absolutely.
Lawrence, will you co-moderate the IBD one with me?
Absolutely, absolutely.
Excellent. Two
Yeah, I love it.
co-elected
Yeah.
specialists. Perfect.
Awesome.
Let's do
All
it.
right, guys.
I'm sorry,
Thank-
everyone.
thanks,
I
everybody.
think I'm going to take a couple of minutes of everyone's time, and I hope you
Sure,
don't
go
mind.
ahead.
I have a question in regards to the usage of NIH stroke score. I'm not a physician. I'm a biostatistician. And I help physicians with their studies. And I was helping the doctors in the University Medical Center in Tirana. They were doing a study about strokes and thromboembolysis. But what I noticed is that the numbers that they report for the NIH stroke score are like 10 or 11 or 13. But I noticed that the numbers that were in the slides, if you had a score of 6, you are supposed to be dead.
Yeah, so that's actually the modified Rankin score, which is a little
Oh.
bit different. The NIH score goes up to 24.
Oh, okay, great. So they are using the updated one, right? Or
We're
What do
using
you
the one
mean?
that goes up to 24.
oh, okay, okay, great. Thank you very much, and great presentation. I really enjoyed it.
Thank you.
Mhm.
And what is your name? I'm sorry, this is
My
the
name
first
is-
time we meet you.
Yeah, my name is Mario. I'm a doctoral student in biostatistics.
Are you
Oh,
in
well, nice
Tirana
to
or
meet
in the
you.
States?
I'm in the States. I'm in Georgia right now.
Excellent.
Oh,
And
okay.
you're doing work with who
Well-
in Tirana?
Yeah, I help them a little bit, but like most of the work that I do is here. And actually,
You work with Dr. Giatta or Drassini, the dean or director?
no, none of them. We have another team here that we work, but also
Okay.
during the summer, I'll have an internship with Merck.
Good for you.
Yeah,
I mean,
thank you.
that's really good for you. Good for
Yeah,
you.
thank you.
Continue the
Mhm.
work. I'll
Yeah,
bring you
and I-
Yeah, well, thank you.
And I
Thank
really enjoy your presentations, even though I understand a lot of stuff, but like not everything.
Me too.
It's okay. Neither did everybody. So it's all
Don't
right.
worry about
You
it.
won't faking it, bud.
Ermelinda made it so easy that even a
Yeah.
first year medical student.
Definitely, she helped a lot. Thank you. Mhm.
Well, thank you, Mario. Thank you for joining us, and thank you, everyone. Hope to
Thanks,
see you
guys. Have a
soon
good night.
next month.
See you for the
Sarah,
next.
how can I help you for this talk?
I'll
Do you
reach
need
out.
some-
I'll reach out. Yeah.
All right, I got slides, I got anything you
Drink the
need.
wine.
All right, you want me to drink during the conference or after? All right.
I don't want
Before
to
and during.
Do like a.
Not to it, everybody. God bless
Not
you.
to Nemir, not to Nemir.
Bye.
Nemir.
Not Nemir.
Good
Bye,
night.
everyone.
Bye.